Thank you so much for joining to the second ever journal club hosted by Representation in Rehab. This will also be a recorded meeting for people who want to watch later on our website. To those who don't know, Representation in Rehab is a fairly new organization that was created to build an online platform of students, residents, and faculty across the country to help increase diversity, equity, and inclusion within our field, PM&R, as well as to, do things like this, encourage scholarly activity, build connections, and things like that, particularly for students who don't have much access to PM&R at their home school. So this is a really great opportunity, and I'm really excited here with some of the presenters we have today and the faculty joining us. So I'll do a quick intro to each of them and hand it off to them. So our first presenter will be Maureen. She's an MS3 from George Washington. And our second student will be Christian from Des Moines University. And our faculty who will be moderating the discussion, kind of leading the journal club as it goes on, will be Dr. Zhang, who's one of our very own from Texas Tech. She is a brand new faculty, TBI faculty at Tech. She did her residency training at UT Houston McGovern and did her fellowship training at Harvard-Spaulding. So we're really excited to have a great group of students and faculty here joining us. And I'll hand it off to our first presenter, Maureen.
Hi, everyone. My name is Maureen Nwizu, and I'm a third-year medical student at George Washington University. And today I'll be presenting the fluoxetine for motor recovery after acute ischemic stroke, otherwise known as the FLAME trial. Okay, so how were the investigators influenced? What influenced the study? Well, there had been prior studies on post-stroke patients studying the effects of vitamins and fluoxetine. Some of the results of the amphetamine were not really promising. However, some of the studies on fluoxetine were promising, and they found out that fluoxetine actually increases motor function when given to patients who had strokes, and also when combined with physical therapy. And SSRIs have also been found to offer some neuroprotection after ischemia. So then the investigators decided to answer this question: does a 3-month treatment with fluoxetine enhance motor recovery when given early after an ischemic stroke to patients with moderate to severe motor deficits? And they recruited participants from 9 stroke units in France, and this article was published in The Lancet in 2011. Okay, so how did they include and exclude participants? Well, they included participants who had acute ischemic stroke within 5 to 10 days of the trial, and who had developed hemiparesis or hemiplegia, who were between 18 to 85 years, and who had a Fugl-Meyer motor scale score of less than or equal to 55. This FMMS score is widely used to measure motor, what would I say? Like how well people are able to complete motor tasks after strokes. And then they excluded patients who had severe deficits that would have prevented them from completing the motor testing. And some other exclusion criteria are listed over here. So this is what the Fugl-Meyer motor scale score looks like. There is a score testing for the upper extremities, and patients can be scored as not completing the task, partially completing or fully completing it, and the same is for the lower extremity. And the study was randomized and it was double-blinded. Okay, so how did they go about the trial? So the participants who were placed in the fluoxetine group we are giving fluoxetine 20 milligrams once a day for 90 days, and then those in the placebo, we are giving placebo for 90 days. And all the participants received regular physical therapy according to the guidelines of their respective stroke facilities. And the primary endpoint of the study was a mean change in FMMS score between day 0 and day 90. And the testing was conducted by a physical therapist at baseline, at day 30, and on the last day. And the highest score was a score of 100, which was normal movement. A score of 0 was flaccid hemiplegia. The highest score that participants could get on the upper limb testing was 66, and 34 for the lower limb. And they were scored as incomplete, partially, or fully performing the tasks. The secondary endpoints were the NIHSS, the Modified Rankin Scale, and the MADRS. The NIHS is the NIH Stroke Scale, which is used to test for severity of strokes. Modified Rankin Scale score is an index used to measure the degree of dependence in daily activities in patients who have had strokes or other neurological disabilities. And the MADRS is known as the Montgomery-Åsberg Depression Rating Scale, used to screen for depression. And an MRS score of 0 to 2 indicated independence in daily activities. 3 to 5 was dependent, and an NIHSS score of 0 to 5 signified less stroke severity. So this is a flow chart of the trial. They randomly assigned 118 patients, 59 to fluoxetine, 59 to placebo. 2 were removed from the fluoxetine group, 3 from placebo, and ultimately 57 were analyzed in the fluoxetine group and 56 in the placebo group. And the investigators were very meticulous when they created the study. So in the event of depression, participants were to receive 20 milligrams of fluoxetine, and the study continued, and blinding also continued. So the patients were analyzed. So all the patients who they had data on were analyzed, and on the last day, for the primary and secondary endpoints in the treatment group, they used either the student's t-test or the Maureen test to analyze the data, and then the treatment and placebo groups data were analyzed with the chi-square test. Okay, so now to the results of the primary endpoint. So on the left, the left is the baseline characteristics. So as you can see on the left, the treatment group and the placebo group were well balanced in terms of demographic characteristics, although the average age was higher in the fluoxetine group, and the participants in the fluoxetine group also had higher frequency of prior strokes, and they also had a higher total FMMS score at baseline. So on the right are the results on day 90. So the primary endpoint, like I said, was a change in FMMS score from day 0 to day 90. And as you can see on the right-hand side, the FMMS score for the total FMMS score and the fluoxetine group was significantly higher. And the scores in the upper and lower limbs were also significantly higher in the fluoxetine group. This is also another diagram of the results of the adjusted mean FMMS total score. And as you can see on the last day, the fluoxetine group also, the result was also significantly higher at the 90 for the fluoxetine group. Okay, so these are the results of the secondary endpoints. And on the left are the baseline scores. So I'll begin with the NIHSS score. So at baseline, the NIHSS score did not significantly differ between the two groups. And at the 90, it didn't significantly differ either. and the probability of having a less severe stroke score of 0 to 5, did not significantly differ at day 90. However, the motor scores for the fluoxetine group were significantly lower than that of the placebo. And then going back to the left, for the MRS score, at baseline, no patients in either group had a modified Rankin score of 0 to 2, and the 0 to 2 score is a score of independence. However, at day 90, you can see that both groups improved in their MRS scores, but the probability of being independent was significantly higher in the fluoxetine group. And then for the MADRS score, moving back to the baseline, you can see that the scores, the distribution was the same, and there wasn't much of a difference at day 90. However, for the adjusted mean, there was a significantly lower MADRS score in the fluoxetine group compared to the placebo group. Okay. So these are some of the adverse events that they documented during the study. Okay, so based on the significantly higher FMMS scores, significantly lower NIHSS scores, and more patients in the fluoxetine group being independent based on the MRS scores, the investigators concluded that fluoxetine is efficacious and clinically significant in promoting global post-ischemic stroke motor recovery. However, they acknowledged some limitations to their study. They had a small sample size. They only included patients with motor deficits, and so their results could not be generalized to all stroke patients, and their treatment duration was also short, and random error could not be excluded. So this also speculated that SSRIs work by encouraging motor outputs, especially when combined with physical therapy. So for future directions, they recommended that other future studies should focus on more functional aspects rather than pure motor testing, because what's it called? They only focus on pure motor function rather than the daily functioning. And they also recommended that the treatment duration be longer, and other studies should focus on whether these positive effects that they discovered of fluoxetine are permanent. And other studies should also try to gain a more understanding of SSRIs and their mechanism of action. And that is it. Does anyone have any questions? Thank you very much.
Great presentation, Maureen. Very clear and concise. I think you got all the key components of the study. And since this is a journal club, I think this study is a very good example of a double-blind randomized controlled clinical trial. It contains patients from multiple centers, and the sample size was decent based on a predetermined calculation. And the article was very well written. So things you're looking for in a RCT trial or paper include the purpose of the study, the setting, inclusion and exclusion criteria, randomization, masking, selection of primary, secondary outcomes, and outcome measures, and treatment regimen, special events management. So in this specific case, the researchers have to consider if the patient develops depression along the way, how they should handle it, because basically it is an exclusion criteria for this study. And then adverse events reporting and statistical analysis, which were all clearly defined and described in the paper. And the method section usually follows with the results, which usually starts with reporting demographic baseline, and then primary, secondary outcomes, and then adverse effects. So in the discussion section, authors usually start with a summarization of their findings. And then, as you can see in this paper, in the first line, it's a very simple, concise statement. We noted a positive effect on motor recovery in patients with acute ischemic stroke who were treated with fluoxetine for 3 months. So it's just a very, very concise statement, cut to the point of the conclusion of the, the study. And then it usually follows by a brief description of the results, and then start interpreting the results or explaining why they achieve the results and how it is comparing to other similar studies. So, and also research papers usually contain a paragraph at the end of the entire discussion section talking about the limitations or disadvantages of the study. There are no perfect study design. So keep in mind, when you design a study or read a paper, always try to be cognizant or critical about what is missing, what is not considered, what is not mentioned there. Would it be a factor that may affect the results of the study? So things to consider. And you will find a pattern when you read more. So this type of article is usually pretty straightforward, but it is really difficult to carry out. So since the publication of the study, everyone got really excited. There was at the very beginning of my career, not really career, like shortly after I graduated from my medical school, and physicians started giving fluoxetine routinely after acute ischemic stroke. So there was really an inspiring finding at the time. However, it is not the end of the story. So let's see what happened later, and Christian will tell us more.
All right, thank you so much. Let me just share my screen really quick. All right, so I'm gonna do this right from the start. All right, so as Sparsh said, I'm Christian. I'm in OMS3 at Des Moines University, currently doing my third-year rotations in San Antonio, Texas. Thanks, Sparsh, for putting this together, Maureen for an awesome presentation, and Dr. Zhang for your mentorship on this. So as the slide suggests, I'm going to talk with you a little bit about the implications of flame, a few of the major follow-up studies, and kind of where we go from here. So let us get started. As Dr. Zhang mentioned, the findings of flame became kind of a big deal in the stroke recovery world and garnered a lot of press coverage for an academic paper. And you can see some of the headlines here, in publications from, laypersons, magazines, and newspapers to, more professional organizations like the Journal of Clinical Psychiatry. And it caused a lot of clinicians as well to start using it on the wards, as Dr. Zhang says, for patient recovery. There was a lot of excitement here. And this just got even more intense in this 2012 meta-analysis by the Cochrane collaboration came out, and they're a British organization that seeks to organize medical research findings to facilitate evidence-based choices about health interventions. And they published, as you can see here, a review looking at 52 trials of SSRIs for use in stroke recovery, and found promising evidence that SSRIs might improve recovery, kind of further adding fuel to the fire around this. The analysis also, however, highlighted the need for further high-quality evidence to both either confirm or refute these findings and to determine the level of risk for adverse events. So we got what I am calling the triumvirate in direct response. The focus, affinity, and effects trial were born, totaling 4,407 participants at 181 hospitals and recovery centers across 5 countries. And before I get into the trials themselves, just wanted to quickly touch on the modified Rankin scale, because as was said by Maureen earlier, there was kind of a shift from wanting to do a bit more of a nuanced way of looking at recovery to kind of a more global functional based status. And as you can see, this is from MD Calc. MRS is scaled from 0 to 6, from full independence and no symptoms, decreasing in levels of independence to finally reaching death at number 6. And I just wanted to pause here really quick and can anyone, kind of tell me what some of the downfalls might be or pitfalls of moving from a more nuanced scale with a longer sliding scale from 0 to 100 to one that only has 6 distinct categories? So essentially, this is a clinician looking at a patient and sticking them in one of these buckets, as opposed to kind of scoring them on individual pieces.
Sensitivity will be decreased.
Yeah, exactly. And so it kind of makes it a little bit more difficult for nuance and for seeing a small change, small but significant change with an intervention, because there's just not a lot of room for a small percent change with only 6 categories. Cool. So the first of these focus took place at 103 hospitals throughout the United Kingdom and caused quite the shock when they came out. The fluoxetine or control under supervision or focus study, very catchy name, had 3,127 participants and showed that fluoxetine 20 milligrams PO daily for 6 months does not significantly improve patients' functional outcomes or survival at 6 and 12 months. So a big difference from the FLAME trial already. And in terms of methods, the 2 biggest differences from FLAME were the duration of fluoxetine intervention, so 6 months versus 3 months in FLAME, and the primary outcome. As I said, these studies used the modified Rankin scale versus the FMMS in the FLAME trial. Much more of a distinct global evaluation versus a more broken down looking at FMMS that looks into motor functioning, sensory function, balance, joint range of motion, joint pain, all scored independently. And as I kind of mentioned in the summary, the primary outcome data showed that fluoxetine showed no significant differences in disability as measured by the modified Rankin scale. And not to get too much into the weeds here, but they used an odds ratio to justify this. And that's just a measure that's an association between an exposure and an outcome. And since the confidence interval of the odds ratio here includes 1, there is no statistically significant differentiation between placebo and intervention on this scale. And then we move on to some of the secondary characteristics, secondary outcomes. And this trial showed that fluoxetine increased the risk of bone fractures and increased mood, but this was not sustained at the 12-month follow-up. Okay, moving on. The next study is the safety and efficacy of fluoxetine on functional outcome after stroke, which really does not spell affinity, but I get what they were going for. And this was at 43 hospitals in Vietnam, Australia, and New Zealand. And again, it showed that 20 milligrams of fluoxetine PO versus placebo given 6 months for 6 months, 2 to 24 days post-stroke, it did not really show a significant statistical difference in the modified Rankin scale. And the big difference here between focus and affinity was the number of participants, which this had 1,280, and the number of hospitals, 43, and the countries involved, but otherwise it looked very similar in terms of methods to the focus trial. And then we'll look at the major differences here, which come in the secondary outcomes. And as you can see here, the fluoxetine group had more falls causing injury, more bone fractures, and more epileptic seizures. And kind of in concordance with focus, there was an increase in mood and emotional control in this study as well in the fluoxetine group. And this one, just as another secondary outcome, showed no significant difference in strength, handability, mobility, activity of daily living, other assessment scales, or death. And then finally, the third of the triumvirate is the effects trial. And the effects trial took place across 35 rehab centers in Sweden and had 1,500 participants. And it again agreed with the first 2, focus and affinity, that the modified Rankin scale primary outcome did not have any significant difference and does not improve functional outcomes. That is the language that they used. In terms of secondary outcomes, again, This study showed lower scores in memory, higher scores in bone fractures and hyponatremia in the treatment group. And it again showed increases in mood and emotional control at 6 months in the fluoxetine compared to placebo. So what does this all mean? The bottom line is the Cochrane group that I brought up earlier, who had that 2012 meta-analysis and was kind of the catalyst for these studies coming to be, published a follow-up meta-analysis in 2021 that concluded, based on the 6 studies deemed low risk of bias, which included focus, affinity, and effects, SSRIs did not reduce disability or dependence. SSRIs did, however, reduce the risk of future depression by about a quarter, but again, led to a slight increase in the risk of seizures and bone fractures. And on the bottom here, you can see that the confidence level of the authors of this meta-analysis was pretty high. Very confident that the results are reliable for the effect on disability and dependency and bone fractures, and moderately confident about the effect on seizure risk. So kind of before I go to the next slide, Dr. Zhang, do you remember what the reaction was when these studies kind of came out after, as a bit of a rebuttal to Flame?
I'm glad you asked this question. So actually during my fellowship interview, during the interview with one facility, one of the interviewer actually asked, what did you read lately? So I mentioned about these 3 trials. And then she immediately responded oh, that's a great point. Their ICU have stopped using SSRI in stroke patients. I was like, wow, you guys are really fast. But I know other facilities are still using it. But so I think one of the goals of this journal club is for you guys to carry out this information, maybe to different facilities and to the acute providers.
Awesome. Yeah, that's basically what I was just about to say. So there was, again, a pretty intense reaction from the press and from different organizations. This last one is not even necessarily scientifically accurate, does not improve outcomes, because it does improve some outcomes, especially mood, but just doesn't improve the primary outcomes. But there was, again, a big backlash. And I, was actually listening to some podcasts, and there's a bit of a discrepancy in the field, because there are those, like the interviewers that you had, Dr. Zhang, that immediately put this into practice. And then there are some who, whether it's because of inertia or because they don't like the way that the study was designed or the interpretation, they continue to use this on the wards. And I don't know if any of you have seen that in your rotations, but it's definitely still happening.
Yeah, I can talk about it quickly. I'm Ashley Sanchez. I'm one of the third-year residents at Northwestern, so up in Chicago. And I would say that we don't get as many people with strokes coming on any sort of SSRI now. If anything, usually, at least not from Northwestern, where we get a lot of our patients from. Usually some of our smaller hospitals out more rural, usually some of them, they'll come in on an SSRI. And depending on how their mood is, we'll kind of taper that off or not. And then the only time that we do really see people who with strokes on SSRIs if they have if they also have depression, really.
Yeah.
Just because getting that initial buy-in with the mood is just so important for their initial recovery in the short term following their stroke. But we don't see it as often now, and probably because of all of this.
Yeah.
I totally
awesome.
agree.
Thank you for that.
Yeah, I totally agree with the rationale of using it if there are 2 purposes there, with mood and potential motor benefits, which may not be so legit right now. But if there is another, goals that you're trying to achieve, I think this is still worth trying.
Yeah.
And you know what? Just one more thing to add. Sorry,
Yeah.
Christian.
Okay.
Whenever we are going to talk to our patients with strokes, that we want to start them on an SSRI, not only we mention the mood benefits, but sometimes we'll vaguely say some studies have shown that it can help improve stroke recovery, just to get the extra buy-in, because not everybody's super thrilled about starting an SSRI that they assume is for depression. A lot of people don't recognize, right, their depressive symptoms, and it's affecting their recovery. Sometimes we throw that vague line in also to get some buy-in for the patients to be willing to take this.
Yeah. It actually just got me thinking that there's, I wonder how much the fact that stroke patients in the FLAME trial who were also depressed got a 40 milligram dose of fluoxetine instead of a 20 milligram dose. I wonder if that had anything to do with kind of some of the results. But anyway, that's neither here nor there. Just to finish up.
Interesting. Oh, I'm so sorry. Hey, it's Roxana. I'm one of the residents over at Stanford. You guys did an incredible job. I mean, truly, like I have heard the studies like discussed, and this was like I don't even know what we were doing on wards. Like this was like the best presentation I've seen of these studies, and I like get everything a lot more now. I guess I'm just kind of curious, just to do like a quick poll, like how often you all still kind of start an SSRI post stroke. I mean, definitely still have people come in from, like Ashley said, from rural places with it on, and but I guess what I'm asking is like how often do you start it like simply for the mood benefit alone? I'm kind of curious.
I think if it's simply for the mood, if I have a concern that the patient is depressed, or the mood is kind of down, which a lot of them may have either because of the stroke, because of location of stroke, or because of this is an acute change. It's kind of an adjustment phase. But if I have concern that mood component is affecting their
Mute.
or in that case, I'm leaning more towards starting SSRI. But not purely for motor recovery at this time, I think.
Yeah, that makes sense. Okay, thank you.
Awesome. Thank you all for your input. This is what a journal club's for, right? To have good talks like this. Awesome. And I just wanted to leave you with this little bit of info.
No one cares.
All right. So anyway,
I'm so sorry. I think we had someone hop on. That was nice to hear. Apologies.
It's okay. When you post things on social media, sometimes you get some trolls, right? It's just kind of the way it goes sometimes. That's okay. Anyway, I just wanted to post these statistics at the end just to say that smart people like you need to look into this, because stroke is a huge problem and we don't really have incredible pharmaceutical interventions yet. So please, when you get out on the wards, when you get out as an attending, do this amazing work because it's very important. And in honor of Halloween, David S. Pumpkins. Any questions, anybody?
No, that was
I would
great.
just
Thank
add,
you so much.
oh yeah, presentations were amazing. Thank you guys so much. Something I think was that our medical students could do whenever they were on the rotations that were very helpful in our stroke patients is sometimes we would have them go around doing the what is the depression screen scale called? You have to get like
PHQ-9?
Yes, it's like 9 questions, PHQ-9. So sometimes in some of our patients, we were more concerned that they were like mood symptoms going on, and we would actually go out with our medical students and just do a brief PHQ-9, and see if they would like actually qualify like for depression, would maybe push the team more leaning towards considering an SSRI. So just keeping all this in mind whenever y'all do your aways or whatever, this is something that could be potentially useful for the team and helpful for your patient as well.
Thank you. That's a really good idea.
Actually, I actually have a question for you, or for anyone who wanted to share your thought. So how would you weigh the risks and benefits? So it seems the fracture concern is a legit one. It seems the hyponatremia or seizure may be iffy because different studies have different conclusions. So how would you like take that factor into your consideration regarding starting someone on SSRI?
I would say the main thing that we talk to our patients about when we're considering starting this is usually first if they can tolerate the GI side effects. Because that's usually the most common thing that's going to come up within the first like week that they started, that if they are not even tolerating that, I don't want to quit it halfway or whatever. So usually the GI and maybe some of the sexual dysfunction side effects are kind of what we first counsel our patients about. I've never talked to them about the risk of a fracture if they're on SSRI, nor hypernatremia. I guess those are not as common, and we monitor their labs anyways. But usually it's more like this can cause GI upset, and as long as you're able to tolerate it first couple of days, it kind of gets better and goes away. So like for them not to want to quit after their first upset stomach they have. And so just kind of counseling them on what to expect so that they're not surprised or upset and more likely to continue it, as it should improve the more they consistently take it. So, and as long as they're able to tolerate that, then we start going up on our dose as well, every like couple of weeks or so. Those are the main two I think that we tend to talk about here. Haven't really heard any of my attendees talk about the fractures or any of the other ones. I don't know, Roxanne, if you've heard anything.
Yeah, I haven't heard of anyone talk about it. I'm like kind of embarrassed now that I'm looking at the research. I'm like, oh, that's a real thing that actually happens, and especially because we're starting it on usually elderly patients. It's something I should probably be more concerned about. One of the issues I've had when starting SSRIs is that even though they're inpatient, we're not usually careful about how we up titrate them. So like, we don't start them like. We either forget to kind of keep on increasing the dose, or we like just start them. Sometimes like we start them on a higher dose when we really should have just like slowly increased it over time to sort of reduce the GI side effects. I definitely should start counseling patients more about the fracture risk, or thinking about that a little bit more. Definitely should be doing the PHQ-9. Really essentially I think what this is teaching me is that I was like, we should really think about this more carefully. Yeah. I don't know. This is I don't know if anyone else has any
That
thoughts.
made great points. Yes, I think the most common things are basically definitely you need to watch for GI side effects and sexual side effects. Basically that are things are mostly brought up by patients or you observe in the clinical setting. I think one of my concerns just by reading these articles, because it seems the data is collected from a large population and it seems legit. So the concern that I have is because especially after acute rehab setting, some of the side effects may happen without seeing by us. And it is happening. It's our blind spot, right? So that's just, I don't have a great answer for this question. And I think, I would keep it in mind. Maybe mention it to the patient as well, just to kind of remind them to be more careful regarding falls and injuries and potential fractures. But I'm not exactly sure how it will affect my prescriptions for SSRI. It's just, I think I was just trying to provoke some discussions, but I don't have a perfect answer for you guys. So, and regarding the SSRI titration, so I think different SSRI have different titration regimens. So sertraline would require the longest titration, and citalopram and escitalopram would be easier to titration because you only have like 5 milligram, 10 milligram, up to 20, but sertraline has a very wide range to go up. So things to consider. Yes, I think go ahead.
I was gonna say, I think we learned in school that generally they use sertraline in elderly populations in general, and people who are more at risk of falls and things like that, because it does have a more beneficial or less harmful side effect profile in that population. Is that true from your experience?
Not necessarily. It depends.
Okay.
I think the 5 SSRIs have all different properties and side effects profiles based on their pharmacodynamics, kinetics, and property stuff.
Yeah.
I feel like we tend to use, is it escitalopram? Because I want something more cardiac friendly. So we tend to have a lot more people with like cardiac issues, which is how they may have gotten their stroke in the first place. So usually when we're debating of which SSRI to start, I feel like we tend to do that one. I don't remember starting too many people on sertraline.
And I had a question, at least from like the mood aspect, with because it does have a delayed, like it takes a little bit of time to get to, that therapeutic dosage. Dr. Zhang, like, could you speak a little bit on that, at least in inpatient rehab, when, you already might have them for a shorter amount of time. So you really can't follow up on that part of their treatment course as well.
Yes, I think fluoxetine takes the longest time, actually, a couple of weeks. And I'm not exactly sure about sertraline, but citalopram and escitalopram would be faster to achieve therapeutic dose range. I think because of the half-life and, metabolism, and I just need more visual references. Cannot call it out on top of my head. So, but I can send it to you later. Any other questions or discussions you guys want to bring up?
Just if there's any other drugs or ongoing trials that you're excited about, and like if you know when the papers are going to be released or anything like that in this patient population.
Motor recovery?
Yeah.
So about medication wise, I don't think so. I think the gold standard is still physical therapy, a lot of exercises and practice. So so actually, I think I want to mention, I want to ask you first, Christian, do you think this is the end of the story about using SSRI for post-stroke motor recovery?
No, I don't actually. And the reason that I'm saying that is because one, they did find a benefit in the FLAME trial, of course, but two, there's just so many different kinds of SSRIs, as you were talking about, with so many different mechanisms of action. And so this is such a fluoxetine focused set of trials that, there are later gen SSRIs like escitalopram that may show benefit down the line, or even newer compounds that we don't know about.
Yeah, exactly. I totally agree. I think we should keep an open mind because all the RCTs are very strictly designed. So when you apply this, the results of the study, you have to be cognizant about their study setting. So I think there are a lot of differences in terms of these three trials comparing to the FLAME trials. So FLAME trial was very selective for ischemic stroke. And all of these three trials included hemorrhagic stroke. And theoretically, from what I remember, that SSRI is not working for hemorrhagic stroke that well as ischemic stroke. I don't know why, but it seems a lot of studies done in hemorrhagic stroke, it didn't help that much. And so this is one component. And then, as Christian mentioned in his presentation already about the choice of the outcome measures. So why the motor function improvement did not carry forward into the functional use of the limbs. So I don't know. And also there's a component of, the modified Rankin scale group or categorize patients in a limited sections rather than having a FMMS has like the rating scale in very, very details of different joint, different muscle groups across upper and lower limbs. So those are considerations. I think we should keep an open mind there. Things may change in the next 10 years, few years. So that's that. So great job, Christian. Basically, you are taking on a mission impossible, synthesizing the essence of all the three RCTs and 2 Cochrane reviews into a short but very organized presentation. Very well done. The idea that we organize a presentation this way is to show you the changes in clinical practice based on the best possible evidence we have for now. So I feel this is a great example. It's not common to have this level of evidence in medicine. And I think in the end, I would like to have Maureen and Christian to share with us one thing that you learned from reading these articles, and one thing that you learned from preparing for the presentation. It can be several things if you would like to share more, just to kind of hopefully to bring up some points for all of us to carry forward.
Go
Maureen,
ahead, Maureen. Yeah.
Okay, I can go first. Well, I had always like thought about SSRIs as only used for depression, so it was interesting to see them being used to enhance motor recovery after strokes. But some studies had found out that SSRIs like fluoxetine have anti-inflammatory properties that contribute to their positive impact on brain recovery or motor recovery after ischemic strokes. And another thing I learned was that the how should I say this? This very systematic way that trials are organized, because I was very impressed that they included the section about what if patients develop depression during the study, which I found very impressive. And they laid out a plan for what would happen if that were to happen. So that was a good way to learn about how RCTs are conducted, because I don't really have much experience with it. And I think the other question, Dr. Zhang, you asked was about what I guess advice we have for the future generations. Is that what you said?
Well, one thing that you learned from preparing for the presentation, like, or presentation skills or things that they want to share with other students.
Well, they can, if they're lucky, they can find a wonderful mentor like you. Or if or not, they can, and if they don't have a wonderful mentor like you and they haven't done journal clubs, and this will be their first time doing a journal club, like it was my first time doing a journal club, and they have no idea where to start, they can go section by section through the article and pick out the important details, and just put that in the PowerPoint presentation. And then they can go through the PowerPoints, present it to a friend, or anyone who can help them pinpoint things that are great, things that need to be changed, and stuff like that.
All right, I can go really quick. So from reading the articles, I basically learned that neurological recovery, especially after a damaging event like TBI or stroke, is super complicated, and it's going to be very hard for a singular compound to compete with something like physical therapy that's so nuanced and multifaceted and directed towards the patient. Like a singular 20 milligram dose of fluoxetine, right? That's not changing in response to how the patient is changing, but physical therapy does. It's iterative. It gets better. You know what I mean? It gets more in tune with that person. It changes based on what needs they have that day versus a different day. And it's just going to be really hard for a medication to do that. So maybe it'll be an adjunct therapy that'll kind of speed up recovery. And in terms of from creating the presentation, as we've kind of, beat to death in this presentation, how choosing a primary outcome can influence conclusions. So the difference between the modified Rankin scale and the FMMS that we were talking about, that was huge for me. I got to dust off my PowerPoint skills that I haven't used since leaving American Express 2.5 years ago, and how important it is to work with your colleagues to stay up to date, because no one can read everything even in your field. Even if you're a subspecialist, there's no way you could read every single paper. So to do things like this where we can kind of share the load and talk about things is really important.
Excellent. So basically my hope for this session is to leave you at least one point, whichever it is, for you to carry forward in your future study or career. And I would definitely hope to bring some brilliant minds here into brain injury medicine. So I hope you had a good time so far. Sparsh, I will give it back to you.
Well, thank y'all so much. Literally everybody did an amazing job. Both presenters, Dr. Zhang, thank you so much, everybody, for your input. This was amazing. And this is more than I could have imagined this journal club to turn out to be. So for future students who are interested, please feel free to reach out and just, keep discussions like this going. Find that mentorship, find those faculty who invest in you, the similar way that Dr. Zhang does with her students. And we look forward to seeing you at the next journal club. So hope everyone has a good night, and see y'all soon.
So proud of you both. Have a great night. Great job.
Thank you so much. Bye, everyone.
Bye, everyone.
Thanks so much.